Hello everyone, welcome back to my YouTube channel Dr.Barki's Ophthalmology Tutorials. Today we will discuss about optic disc changes seen in glaucoma patients. In this video I will be discussing about the changes which occur in the optic nerve head in glaucoma patients, why these changes occur, how to examine them, how to measure the optic disc size, cup size, how to document this, and what is the significance of these changes. Okay, so without much delay, let's begin our video. So first we will describe what is normal optic disc. As you can see in this picture, this is the optic disc. The central white part is the optic cup, okay, and the area which is adjacent to the optic disc is called as the peripapillary area, and these are the retinal nerve fibers which will exit through the optic disc. So when you examine the patient of glaucoma, it should be described under the headings of optic disc, the peripapillary area, and the retinal nerve fiber layer. So when you examine the optic disc proper, it should be under the headings of the optic disc size and shape, the optic cup size, shape, depth and the lamellar dot sign, neuroretinal rim, again shape of the neuroretinal rim and color of it, CDR, that is cup disc ratio, both horizontal and the vertical measurements, and vessels over the optic disc, as well as the Kestenbaum sign. So these are the things which you see in optic disc. In the peripapillary area, we have alpha zone and the beta zone and the retinal nerve fiber layer examination. So when you examine the fundus of the glaucoma patient, all these things should be examined properly. So let's discuss each one now. So coming to the optic disc, the normal optic disc size. So this is the normal optic disc size. It is about 1.5 millimeter square. Okay, the size varies with race. It is small in whites, intermediate in Asians, whereas it's largest in blacks. Okay, so how you measure this optic disc size? That is by using either direct ophthalmoscope or by using slit lamp biomicroscopy. When you use direct ophthalmoscope, that is in Welschling type of direct ophthalmoscope, the smallest aperture which is corresponding to 5 degree, when you use this aperture, it will throw a circular spot of light which has an area of 1.7 millimeter square, which roughly corresponds to your optic nerve head size. So with this you can tell whether the optic disc is of normal size, bigger one or smaller one. But most commonly used is by using slit lamp biomicroscopy, that is with the help of slit lamp as well as using 78 diopter lens or the 90 diopter convex lenses. In this, the procedure is ask the patient to sit in front of the slit lamp, okay, and the examiner will use either 78D or the 90D lens and focus over the optic disc, and you will examine the various parts of the optic disc. When you want to measure the size of the optic disc, the slit which is formed by your slit lamp should be adjusted to the height of the optic disc, okay, as well as the width of the optic disc. Then there will be a reading in the scale of the slit lamp, okay, and depending upon which lens you are using, whether you are using 78D or 90D, you have to multiply that scale reading by the corresponding factors. That is, for 78D multiply by 1.1 and for 90D multiply by 1.3. Okay, so that will give the area of the disc in millimeter square. So this is how you measure the optic disc size using slit lamp biomicroscopy. Does the refractive error of the patient have an effect on this optic disc size? Yes. In hypermetropes of more than +5, the optic disc is small, whereas in myopes it is larger. As a macro disc, when the disc area is more than 4.2 millimeter square. It can be seen in cases of morning glory syndrome, as it is seen in this case, the very large disc, okay, and even in case of progressive myopia as well as uncontrolled glaucoma. Whereas small discs are associated with optic nerve head drusen's, pseudopapilloedema and non-arteritic type of AAOM. Okay, so this is about the size of the optic disc. The next parameter what you see in the optic disc evaluation is the shape of the optic disc. Usually the optic disc is vertically oval in shape, okay, but shape has no significance except in cases of high astigmatism, where the shape of the disc correlate with the axis of the astigmatism, and in cases of myopia of more than 12 diopters, the disc becomes more oval due to unevenly distributed traction factors across the optic disc. Next, coming to the neuroretinal rim. So what is neuroretinal rim? As you can see in this picture, this is the optic disc margin, and this whitish thing inside is the optic cup, and this is the optic cup margin. So the distance between these two is called as neuroretinal rim. When you are checking for the neuroretinal rim, you should always concentrate on the color of the neuroretinal rim and the width of the neuroretinal rim in various quadrants. Okay. Normally, the color of the neuroretinal rim is pink. Okay. Even in glaucoma patients also, the neuroretinal rim remains pink until the end stage. Okay. When the disc damage is secondary to other causes where there is a factor of ischemia, the neuroretinal rim becomes pale. Okay. So you should differentiate the pallor of the cup from the pallor of the neuroretinal rim in those cases. Otherwise, you will confuse that as the optic disc cupping. And the second point in the neuroretinal rim examination is the width of neuroretinal rim in various quadrants. It usually follows the ISNT rule, that is ISNT rule, that is inferior rim is the thickest, followed by superior one, followed by nasal, and then the temporal. The temporal is always thinnest. So why there is uneven distribution of this neuroretinal rim? There are three factors which contribute to this unevenness. The first one is the shape of the optic disc is vertically oval, whereas the shape of the optic cup is horizontally oval. So there is uneven width of the neuroretinal rim. And the second is the center of the optic disc is 0.5 mm horizontally above the center of the fovea. Hence, more number of the axons go through the inferior part, leading to thick inferior part of the neuroretinal rim. And the third factor is the morphology of the pores through which the axons of the ganglion cell exit, and the connective tissue which is there in between the pores. In the superior and the inferior poles, these pores are largest and there is least interpore connective tissue. But it is opposite in case of nasal and temporal. Okay. So this is about the neuroretinal rim, that is the color of the neuroretinal rim and the normal width of the neuroretinal rim in the various quadrants. So what happens in the glaucoma? There is thinning of the neuroretinal rim. It can either be concentric thinning with a progressive enlargement of the cup, or it can be a sectoral thinning involving only one quadrant, or even it can even be a notch like thinning of the neuroretinal rim. The neuroretinal rim thinning is more common in the inferotemporal part first, followed by superotemporal, and then the temporal region. And the last to be affected is the nasal neuroretinal rim. The reason for this is, it is usually said that the sector which is away from the bundle of vessels, okay, the bundle of the central retinal vessel is usually affected first. That's why the temporal quadrant thins out first and the nasal quadrant is at the last. Okay. And the next thing what you examine is the optic cup. In the optic cup, it is examined under the headings of the size of the optic cup, shape of the optic cup, the cup disc ratio, and the depth of the optic cup. Okay. So as you can see in this picture, this is the optic disc and the white thing inside is the optic cup, where it is the empty space. Okay. Or there is only lamina cribrosa and the axons are not passing through this part, leading to the optic cup formation. And the size of the optic cup usually correlates with the size of the optic disc. That is, the large optic disc will usually have the macro cup or the large cups, but it can also be physiologically large cup, and even the myopic degeneration patients and the glaucomatous atrophy patients will also have large cup. Whereas the size of the optic cup is very small in small disc. It looks as if there is no cup at all in case of small disc. That's why it is very important to measure the optic disc size, because a very small cup of even 0.2 to 0.3 may be very significant in small disc. That may indicate that patient is having glaucoma, but it may not be significant when the optic disc size itself is large. Okay. So why this optic cupping occurs? It's because of the degeneration of the retinal nerve fiber layer axons. So it can be a diffuse degeneration or it can be focal degeneration. As I told previously, if there is diffuse degeneration, there is concentric enlargement of the optic cup and progressive thinning of the neuroretinal rim. If it is focal degeneration, it presents as a notch either superiorly or inferiorly, which I will be showing later. And this optic cupping occurs only when there is very high pressure, okay, of almost to more than 40 mm of mercury. Optic cup can even be transient and reversible in case of pediatric age group. Next, coming to the cup disc ratio. So this is the frequent word which you hear when you are discussing about any glaucoma patient. So what is cup disc ratio? This is the ratio of the size of the cup to the size of the optic disc. and the normal cup disc ratio is 0.3. You should always measure both horizontal as well as vertical cup disc ratio. Usually the horizontal CDR is slightly more than the vertical CDR because of the placement of the cup. Okay. If the vertical CDR is more than the horizontal one, it indicates that there is superior and inferior rim thinning, which is in favor of glaucoma always. Okay. So this is how you measure the cup disc ratio. Next important aspect is the depth of the cup. So in some cases, the predominant pattern of early glaucomatous optic atrophy will be the deepening of cup. So the depth of cup is also important. So how we measure the depth of the cup? That is done by using direct ophthalmoscope. First you focus upon the neuroretinal rim of the optic disc. At that time the center of the optic cup is blurred. Then go on focusing by changing the lens till you see the center of the cup as clear. Then you note down how many diopters of lenses you have moved. Depending upon that, you can calculate the depth of optic cup. There is one more word which is used when you are discussing about the depth of cup, that is saucerization of the cup. It is nothing but a pattern of early glaucomatous change in which there is diffuse shallowing of the cup which extends to disc margin with the retention of the central pale cup. So this can be an early sign of glaucoma. Means there is diffuse posterior bowing of the optic disc. This saucerization can be either diffuse or focal. When it is focal, it involves more commonly the inferotemporal region. There will be localized shallow sloping of the cup. Okay. And when it is retaining the normal NRR color in this focal saucerization, it is called as tinted halo. Okay. This is about saucerization. Then if the glaucoma is still progressing, this neuroretinal rim what you are seeing will also disappear and the optic disc becomes completely pale, that is completely white with no neuroretinal rim, and the vessels will be exiting at the margin itself, and there will be complete posterior bowing of the optic disc, that is called as bean pot appearance. So as you can see in this picture, if you take the cross section of the optic disc, there will be extreme posterior displacement of the lamina with the undermining of the disc margin. So this is the bean pot. This is, you can imagine, this is the optic disc. So there is complete posterior bowing of the optic disc with the undermining of the margin, giving rise to the bean pot appearance. And this bean pot appearance is most common when the patient is having total cupping. So in this picture you can see there is total cupping, means the optic disc is completely pale. Okay, the optic disc is almost completely pale with very thin NRR, and the vessels are almost exiting at the margin itself. And one more important thing which you should see when you are examining the optic cup is the lamellar dot sign. Lamellar dot sign, also called as shadow sign. As you can see in this picture, there are some dot like things in the inferior half of the disc. Okay, this is due to exposure of the underlying lamina cribrosa by deepening of the cup, and it is often recognized as grey fenestrations in the lamina cribrosa. And when you examine through the ophthalmoscope or the slit lamp biomicroscopy, you will see dot like things in the depth of the optic cup. So this is lamellar dot sign. So I have discussed the optic cup under the headings of size of the optic cup configuration, CDR, that is cup disc ratio, depth of the cup, in that saucerization, bean pot appearance of the optic cup, and the lamellar dot sign. So when you are looking into the optic cup, carefully look into these points and note down. Okay. Next, coming to the appearance of vessels over the optic disc. So normally when the neuroretinal rim is very much intact, the vessels usually pass perpendicularly through the disc tissue to reach the retina. Now because there is NRR thinning, so there will be changes in the appearance and the way the vessels pass through the optic disc. Okay, and one of those is the circumlinear vessel. As the cup enlarges and there is thinning of the optic disc on the nasal side also, the vessels are dragged towards the nasal side. Okay, so that gives the appearance of the nasalization of the vessel. Though this is not so much important, the vertical eccentricity of the central vessels is related to the glaucomatous optic atrophy. And the second change which occurs is the vessels which were going perpendicularly, now since there is thinning of the nasal part of the optic disc, these are drawn back and then they come along the margin of the optic disc. So this course of vessels is called as the circumlinear vessels. That is, there is change in the direction of vessels which pass circumferentially across the temporal aspect of the cup. So these are called as circumlinear vessel. And so if the NRR loss progresses, the vessel will lose the support of the neuroretinal rim and this vessel becomes bare. This is called as baring of circumlinear vessel. So then either just be circumlinear vessel as it is seen in this case, or it can be the baring of circumlinear vessel which is seen in this picture. Okay. And this is well appreciated when you take the serial pictures of the patient optic disc and document and observe. You will be appreciating the course of the vessel which is changing as the NRR thins out. Next we will see about the notching of the NRR. This I have already explained in the neuroretinal rim. Now I am showing with the pictures. As you can see in this picture, the inferior rim is not uniformly thinned out like this. Okay, there is a bend like this and it is coming. Okay, so this is called as notching. It can be seen either inferiorly or superiorly also. This is one more picture showing the inferior notching. Okay, so the neuroretinal rim is not appreciated in a small segment. Okay, the nasalization of vessels I have already explained. Okay, because of the thinning of the nasal part of the neuroretinal rim, the whole bundle of the central retinal vessel is pulled nasally, leading to the nasalization. Okay, next important sign is the Bayonetting sign. So what happens normally, this vessel would have come over the neuroretinal rim like this, but since there is deep cupping here, okay, since there is cupping here, this vessel will bend along the depth of the cup. So when you examine the patient with a slit lamp, okay, you may just appreciate the course of vessel and then the course which is just coming over the neuroretinal rim. You will miss this part. It looks as if it is broken. This is called as the Bayonetting. When the local thinning of the neuroretinal rim reaches almost to the disc margin, there is sharpening of the disc margin. So if the retinal vessels cross this sharpened rim, it will bend sharply at the edge of the disc, creating the Bayonetting sign. Okay. Coming to the next feature which is seen over the optic disc is the optic disc hemorrhage. These are the splinter shaped hemorrhages which typically cross the disc margin. Okay. These can appear and disappear, and again when you examine the patient again once more it may reappear. So this is not a constant finding what you see when you examine the optic disc. And even the papillary part of the hemorrhage can disappear sometime, leading to only the visibility of the extra papillary part of the hemorrhage. Okay, the common location is the inferior quadrant. It is more commonly seen in normotensive glaucoma patients and the glaucoma patients who have associated diabetes mellitus. And it is seen in early to mid stages of the glaucoma damage, and it decreases usually when the glaucoma advances. Though not pathognomic of glaucoma is a significant finding as it appears before even there is Rnfl defect or the notch. Okay, so that is the significance of optic disc hemorrhage. This is one more picture where you can appreciate there is optic disc hemorrhage in the inferotemporal quadrant. Before going to discussion of the next part, that is the peripapillary area, let's see what are the changes which are seen in this disc. Okay, so this is the optic disc. Measure the size and shape of the optic disc. The optic cup, again measure the size, depth of the optic cup. Here the CDR, that is the cup disc ratio, horizontally it's around 0.6. Okay, vertically is also it's almost 0.6, but there is inferior notching as you can see in this neuroretinal rim. Okay, and there are multiple dots like dot-like thing, that is nothing but your lamellar dot sign, and there is one disc hemorrhage here. Okay, and there is bearing of this circumlinear vessel as you can appreciate. Okay, and there is Bayonetting sign also in this. If you follow this vessel, it's coming here and it's abruptly coming in this way. So there is broken appearance of the vessel also, and there is one disc hemorrhage also. So this is how you should examine the optic disc. To the peripapillary area. So as you can see in this picture, the second zone is the optic disc. The central one is the optic cup, and the third is the scleral lip. Fourth is called as beta zone, and the fifth is alpha zone. Okay. So what is scleral lip? It is thin, evenly distributed, white ring that surrounds the disc margin, full 360 degree. It represents anterior extension of the sclera between choroid and the optic nerve head. So the fourth one which is marked here is the chorioscleral crescent, also called as beta zone. It is broader, little irregular, incomplete area of depigmentation. It is due to retraction of the retinal pigment epithelium from the disc margin. It is associated with thinning of the choroid next to disc with the exposure of the sclera. It is seen more commonly in the myopic patients, and it is seen that the ratio of area of beta zone to that of the disc area is more in cases of glaucomatous damage secondary to ocular hypertension. Last zone is the alpha zone, which is marked as 5 here, okay, also called as peripapillary crescent of pigmentation. The alpha zone is pigmented, whereas the beta zone is non-pigmented. Alpha zone is because of malposition of the embryonic fold with a double layer or irregularity of the retinal pigmentary epithelium. So what is the significance of this alpha and beta zone? So recognition of these alpha and beta zone is important in clinical discrimination between glaucomatous disc damage from other causes of disc damage. And to some extent it will indicate the progression of the glaucomatous damage. Okay, as you can see in this picture, this is the beta zone which is surrounding the disc and it is little non-pigmented, whereas this is the alpha zone which is having pigmentation. Coming to the next important thing, that is the Kestenbaum index. It is not just confined to glaucomatous optic disc. It is more important when you want to assess the progression of the disc damage either due to glaucoma or due to any other causes. Even you can differentiate hyperemia also. So what is Kestenbaum index? It is nothing but number of capillaries which are counted over the optic disc. Means literally you should count the capillaries when you examine the optic disc using slit lamp biomicroscopy. So normal is up to 10 is considered as normal. In optic atrophy, as you can see in these two pictures, the capillary count will be decreased to less than 6, and in case of hyperemia of the disc, the capillary count will be more than 12. So this will be helpful when you are following up the patient. The next important aspect in examination of the glaucoma is retinal nerve fiber layer defect. Whenever there is loss of axonal bundles, it will produce a visible defect in the retinal nerve fiber layer. Okay. And to know this retinal nerve fiber layer, the fundus is always examined under red-free light, okay, to highlight the defect area. It appears as dark stripes, as you can see in this picture. Dark stripes are the wedge-shaped defects in the peripapillary area, which are parallel to the course of the nerve fiber layer. Okay, so you can see that there is a wedge-shaped defect both superiorly and inferiorly to the optic disc. So this indicates that there is some amount of retinal nerve fiber layer damage. This defect in the retinal nerve fiber layer highly correlates with the visual field changes, the neuroretinal rim area, and even the fluorescent filling defects. These defects can be diffuse or generalized loss of the retinal nerve fiber, or it can be sectoral as it is shown in this picture. So coming to the differential diagnosis for the glaucomatous optic atrophy, this includes the congenital anomalies of the optic disc like colobomas of the optic nerve head. Okay, here the defect involves the entire disc which is enlarged and excavated. Visual field defects are similar to that are seen in the glaucoma, but it is not progressive. The example for this is the morning glory syndrome. In the congenital optic disc pit also, as you can see in this picture, so there is congenital optic disc pit. It is a localized pale depressed area which is usually near the temporal or inferotemporal margin of the disc. These patients will usually have the vision defect due to macular or extramacular serous detachment, okay, which may not be seen in the glaucoma patients. And in other non-glaucomatous causes of optic nerve atrophy, we have anterior ischemic optic neuropathy, compressive lesions of the optic nerve, even the intracranial aneurysms. But the main differentiating feature is there is pallor of the neuroretinal rim in these causes, but in glaucoma, whatever remaining neuroretinal rim is there, that is still pink. Okay. So all this what I explained till now is mainly for postgraduate students. For undergraduates, just remember that the glaucoma affects the optic disc. Okay, there will be changes in the optic disc. Optic disc includes neuroretinal rim and the optic cup. In glaucoma, there is thinning of the neuroretinal rim and enlargement of the optic cup, which is shown as the CDR or the cup disc ratio. Okay, as the glaucoma progresses, the CDR will also increase and the depth of the cup will also increase. So we will be able to appreciate some signs like lamellar dot sign, Bayonetting sign, bearing of circumlinear vessels, and there will be some amount of peripapillary atrophy, disc hemorrhages. Okay, so if you remember this much in the disc changes of glaucoma. That's more than enough for undergraduates. So hope my video is useful to all of you. If you find this useful, please do subscribe to my channel. Press the bell icon for the further notification. Do like and share my videos. Thanks for watching.